Quite hear you, but I think I'll get. There we go. All right. Good morning, everyone, and welcome to the first Falls Free Friday webinar of 2025. My name is Megan Passano, and I work with the Georgia Department of Public Health Injury Prevention Program, and will be facilitating our session for today. To start, we'd like to go over a few housekeeping items. This presentation will be recorded and be available via the Injury Prevention Research Center at Emory's YouTube channel. To reduce background noise, we do ask that you keep yourself muted for the first portion of the session. Once we reach the discussion portion at the very end, we welcome you to come off mute to ask questions or engage in the chat. If we do not have time to address all the questions in this session, we will be sure to get the answer to you. And lastly, we would like to thank the entire Fall Prevention Task Force for their dedication and expertise in bringing you this virtual session today. So this fall tree session is titled Dementia, Delirium, and Fall Prevention, and I'd like to introduce our speaker for today, Ms. Jennifer De La Cruz with Mercer University. So Jennifer is the Chair and Program Director of the Mercer University Physician Assistant Studies Program in Atlanta, Georgia. At Mercer, she teaches clinical medicine and geriatrics and serves as part of an interprofessional team within the Geriatric Workforce Enhancement Program, which is led by Emory University. In addition to her academic leadership, she continues to practice clinically as a physician assistant and currently working in geriatrics. Professor De La Cruz has been recognized for her commitment to education and to the profession, receiving the Mercer University College of Health Professions Excellence in Teaching Award, as well as the Faculty of the Year Award from the Georgia Association of Physician Assistants. She is deeply passionate about advancing care for older adults and dedicated to improving their health, independence, and quality of life. So without further ado, I will pass it over to Ms. Jennifer and we will get the presentation started.
All right, thanks so much, Megan, and thanks to all of you for inviting me. I'm really passionate about the topic that we're going to be talking about today, so I'm interested in sharing some information, but then also talking towards the end about your experiences and your work and your experience. Okay, so let me just share this. Does that look good, Megan?
Looks good, yes.
All right, great. Okay, so today we're going to be talking about dementia, delirium, and fall prevention. But before we get started, I just want to tell you a little bit more about me and my work in my different hats I wear. So, as Megan said, I am a professor at Mercer University. I'm a practicing physician assistant. I see patients in skilled nursing facilities. And here at Mercer, I'm part of an interprofessional group that is part of a larger geriatric workforce enhancement program led by Emory University. Our group here at Mercer we call ourselves Engage. And we've been working on creating age-friendly curriculum for older adults, for health profession students within Mercer University and elsewhere. We work in collaboration with Georgia Gear. So a lot of what we're going to be talking about today, I want to talk about through the lens of an age-friendly framework of how we look at caring for those with dementia, delirium, and preventing falls. So the age-friendly framework was made back in the 2014, and it basically has 4 pillars in providing age-friendly care. And those pillars are what matters, medication, mind, and mobility. And so the concept is that any of us that work with older adults, whether we're a medical provider, a pharmacist, a physical therapist, a social worker, every time we interact with older adults, we want to consider these 4 pillars of providing age-friendly care, which are what matters to the patient. We want to prioritize what's important to the person. Medication, we want to review medications to avoid any medications that may cause harm with cognition or mobility. In mobility, we want to make sure that our patients can move safely in a way that avoids falls and near falls. And with mind and mentation, we want to make sure that we're screening to prevent, identify, and manage conditions like dementia, depression, and delirium. So the forum's framework, looking at things through that lens, helps guides quality care for older adults, and it frames how we'll be thinking about today's topic. Okay, our goals for today. Hopefully by the end of this presentation, you will be able to describe the differences between dementia and delirium, and what features are specific to each of those conditions. You'll be able to describe the reason for the increased fall risk in individuals with dementia and delirium, and describe prevention strategies associated with these two conditions. Also, we'll talk in general about ways to promote and protect brain health throughout the lifespan. And then we'll talk about how to know when to reach out for help. Okay, so very quickly, when we think about a healthy brain, brain health covers many different domains from cognitive, sensory, emotional, and motor, including language and emotional regulation. Brain health helps us stay independent and be able to do what matters to us, what we want to do in our life, so that we can have meaningful relationships, live a fulfilling life. Many people assume that cognitive decline is an inevitable part of aging, but that is not true. While there are some physiologic normal changes related to aging, a significant decline in cognition is not normal. So the good news is that there are things we can do to try to maintain our brain health throughout our life, and some of these things also contribute to reducing our risk of falls in ourselves and older adults. Okay, so we're going to talk quickly to sort of summarize what dementia is and then what delirium is and how we tell the two apart. So we'll start with dementia. Dementia is a general term for a decline in mental ability that is severe enough to interfere with daily life. It's not a specific disease. It's more like an umbrella term that covers a variety of conditions, the most common of which is Alzheimer's disease. Dementia impacts our memory, reasoning, communication, and our ability to carry out everyday tasks that allow us to be independent. Dementia typically progresses over time, and while there's no definitive cure, early diagnosis and early support and planning for the patient and their family and loved ones can be really helpful and meaningful in improving quality of life of patients and families that have different types of dementia. So the risk factors for dementia, age is our biggest risk factor. The older we get, the more risk we have of developing one of these dementias. Also family history, if a patient may have heart disease, diabetes, if they're a smoker, and even sometimes hearing loss has been linked to cognitive decline. So our brain is closely connected with other systems in our body. So our heart and blood vessels that help support the proper functioning of our brain. So when we think about things we can do to help prevent some of these things, just good daily habits as far as healthy exercise, diet, social connections can be helpful. Social isolation is linked to a higher risk of developing some dementias, and it's possibly due to a reduced cognitive stimulation. So those are some risk factors, some of which are modifiable and some of which are not. And these are different types of dementia. Like I said, Alzheimer's disease is the most common. About 60 to 80% of individuals with dementia have Alzheimer's disease. And this is characterized by memory loss, difficulty learning new information, and a gradual worsening over time. The pathophysiology is that there are brain changes that happen when there are plaques and beta amyloid plaques that form in the brain, along with tau tangles that contribute to the changes in memory. Some early signs of Alzheimer's includes forgetting recent conversations one has had, or maybe missing appointments, things like that. Another type of dementia is frontotemporal dementia. Um, this one thing that differentiates this is that it tends to impact younger adults, frequently under the age of 65. And with this, there are abnormal amounts or forms of tau and TDP-43 proteins that accumulate inside neurons in the frontal and temporal lobe. So with this particular disease, a patient may have personality and behavior changes that occur first. Some examples of that may be disinhibition or apathy or poor judgment, and the memory can remain intact, at least early on. There are some other variants of this that impact speech production and comprehension also. The next type of dementia we'll talk about quickly is Lewy body dementia. And this is a dementia that shares some features with Parkinson's disease. It's caused by abnormal deposits of alpha-synuclein protein, or Lewy bodies they're called, that affect the brain's chemical messengers. And so with this, people frequently may have visual hallucinations, and later in the course, they may develop movement problems similar to what you see in Parkinson's. You'll also see fluctuations in alertness, where a patient may be very difficult to arouse one day, and then another day may be very hyper and very active. That kind of changes from day to day. Also, people with Lewy body dementia may have very vivid dreams, or REM, sleep behavior disorder. That's where people actually act out what they're dreaming. Um, People with Lewy body dementia, providers have to be very careful because this group of patients are very highly sensitive to certain medications like antipsychotic medications. So it's very important that providers understand that diagnosis so we can be careful about medications that we may prescribe. The last type that we'll talk about today is vascular dementia. And this is basically caused by issues with the blood vessels. So if there's reduced blood flow to the brain, possibly maybe after a stroke or some microvascular damage, you can have these types of problems. Frequently, vascular dementia can coexist with Alzheimer's, so it becomes a mixed type of dementia. And with vascular dementia, the other thing you see is it can have an abrupt onset with kind of a stepwise progression where they'll be at baseline and then they'll have a decline in their cognitive state and be stable for a little while. All right, so those are some of the different types. There's other things that can present that looks clinically initially like it may be dementia. Things like normal pressure hydrocephalus can mimic dementia, but that frequently is reversible with shunting. There's also Parkinson's disease dementia, which is where the patient has those more movement symptoms, classic of Parkinson's early on, and then that changes over time. The key point here is that different types of dementia present differently, and so behavior or motor changes, memory changes need to be talked about with healthcare providers so that diagnostics can be done, and so the family and the patient understands what's happening, and then they can plan for safety in the way they move about and the way they get to participate in things that matter to them as their disease progresses. Okay, so some dementia warning signs would be a change in memory that's disrupting life, Difficulty planning or solving problems. If you have a patient that's always been able to balance their checkbook and now suddenly they may be having issues with that, that can be a clue. Confusion with dates, times, although some of us always can have these kind of things periodically, it would become a more routine thing that family and loved ones would notice. Um, Trouble following conversations and potentially withdrawal or changes in mood. So early detection allows us to kind of open the door for different treatment modalities that may be available to these patients, planning and support. So when we think about fall prevention in patients with dementia, let's think about how we can decrease the risk of falls. And if we think about risk reduction through the lens of the 4Ms framework for age-friendly care, um, that can also give us some insight and ideas about how to holistically decrease risk of falls in these patients. So people with dementia are 2 to 3 times more likely to fall, and when they do, the outcomes are frequently more severe. There's greater risk of injury, greater risk of hospitalization, greater risk of long-term functional decline. So fall prevention in our patients with dementia needs to be proactive, personalized, and holistic. So it starts with medical providers, social workers asking the question, have you in the past 30 days had a fall or a near fall? We have to just be aware of when this is happening. So we have to screen them for any risk of falls or recent falls. And then we need to proactively talk about these prevention strategies in the hopes that we avoid a fall, right? So with environmental hazards, we start kind of with the basics. We want to remove trip hazards like loose rugs, cords, clutter. We want to improve lighting, install grab bars. And for someone with dementia, visual spatial perception may be altered. So being sure we have contrasting colors and clear pathways and sort of consistent layouts are very helpful to this patient population. Um, with mobility and strength, decline in balance and strength is common in this patient population, but it's not inevitable. So we need to encourage regular physical activities. We need to refer early to physical therapy and occupational therapy. So they can also help with strengthening regimens, but also making sure that, for example, they're using assistive devices appropriately and that they're fitted properly, and that they have the cognitive ability to use the assistive devices appropriately. So safe movement helps maintain their independence and reduces fall risk. In regard to routine and familiarity, that's a very important piece of caring for patients with dementia. Having a routine that they can be used to following daily is helpful and can decrease confusion and disorientation. Keeping these routines consistent, having cues available, like maybe calendars or clocks, and just minimizing unnecessary changes to help reduce the risk of wandering, falls, things like that. In regard to medications, we do this with all of our older adult patients when we're providing age-friendly care. We want to make sure that we are frequently reviewing medications to make sure the patient is, number one, able to take them on their own independently correctly, because you can imagine if you take your blood pressure 2 or 3 times in one day because you forgot that you took it already, that could cause blood pressure issues and lead to falls. Lots of other medications can increase risk of falls, like sedatives, anticholinergics, antihypertensives. So we need to be sure that these patients are only on needed medications that are working and helpful and that do not interfere with the other 4Ms, like doing what matters, mentation, and mobility. So we want to simplify these regimens as much as possible. And then supervision and support. Even with all these other things we've talked about in place, people with dementia will typically need extra supervision, not to restrict their activity, but to make sure that they're being able to do the things that matter to them in a safe way. So it's important to involve family members or caregivers, considering alert systems. Apple Watches now have fall alerts where the watch will automatically call the caregivers if there's a fall, just to maximize our engagement with these patients. Okay, so that was dementia. Switching over to delirium. Delirium, if someone just rolls into the emergency department and you have no idea of their history, it's very difficult sometimes to tell the difference between dementia and delirium, but it's critical in appropriate care of that patient. So delirium is an acute or sudden change in mental status. May look like confusion, disorientation, extreme drowsiness, or agitation. And it's typically caused by a medical issue, such as an infection, a medication adverse effect, or dehydration. And it's usually reversible. So if you take care of whatever the underlying cause is, typically it's reversible. This can be dangerous if it's missed, though. So if you have a medical provider that just assumes, oh, this patient just has dementia, this is probably normal for them, they may not do an appropriate workup. So it's important to consider that. So this slide just kind of highlights some of the key differences between dementia and delirium. Dementia develops slowly and gets worse over time, while delirium comes on more quickly and can fluctuate throughout the day. One hallmark of delirium is poor attention. So you might notice that someone can't focus or follow a conversation. And it's important to remember that delirium is a medical emergency. Something is wrong that needs to be worked up and treated. Confusing the two of these, dementia and delirium, will delay care and can end up having worse results. So these are just some causes of delirium. Infections, especially urinary tract infections and pneumonia, are common triggers in older adults. Medications, especially those that affect the brain, can also play a role. We've talked about some of those. Dehydration or poor nutritional status can contribute to developing delirium. Unmanaged pain can result in delirium, lack of sleep, and hospitalization. So anytime you take an older adult, especially in an ICU where typically there's people in and out 24 hours a day, it can contribute to the development of delirium. So why does it matter? We cannot miss this diagnosis. So delirium can potentially be mistaken for dementia and vice versa. So the real key is we have to talk to someone who knows the patient's baseline, who can tell us, is this how grandma or grandpa typically behaves, or is this a significant change? So it's very important. We teach all of our students, you have to get a hold of a family member or caregiver to talk with them about what this patient's baseline is. So delirium can lead to really serious complications like falls, longer hospital stays, and even potentially death, if it's not diagnosed and addressed early on. So the awareness and accurate diagnosis matter. It's not just about naming a condition, it's about giving people the care that they really deserve and need for better outcomes. So in regard to fall prevention and delirium, like we've talked about, delirium is always a symptom of something else: infection, dehydration, pain, a side effect. And so it's really important that we get to the heart of what's causing the issue to treat that. In regard to environmental control, people with delirium are frequently, they may be agitated, they may be confused about what's going on. So all of that confusion, agitation increases a risk of a fall. So the last thing we want is someone, for example, who has a urinary tract infection, who's at the hospital, they're very confused because of the delirium that's developed from the UTI. The last thing we want is for them to try to do something that is not safe, mobility wise, and they fall and break a hip. And now we're in a much, much worse situation, right? So environmental controls, uh, decreasing any confusing or disorienting things. We want to provide orientation and reassurance. Frequently, patients that are in the hospital will ask for a family member to come and just be with the patient as a source of reassurance and a familiar face. We want to absolutely try not to use physical restraints, which are sometimes used during hospital stays, because that can only worsen agitation and increase fall risk. Um, so all these things together, trying to promote safe mobility, safe um, reassurance by having a familiar face there can decrease risk of fall. Okay, so falls in individuals with dementia and delirium often happen not really necessarily because of weakness alone, but due to sort of a complex interaction of physical and cognitive factors. In both of these groups of patients, they may forget that they need assistance. They may misinterpret their environment, or try to stand up too quickly when they're confused. Delirium adds that fluctuating alertness, and misinterpretations also of what's going on around them. So understanding why these falls happens help us build better prevention strategies. So as we're looking at all these things, you really, with patients with dementia and delirium, when you think about fall prevention, you have to really think holistically about all the different angles to look at in regards to fall prevention. And it's important that we do. The consequences of a fall can be devastating, especially in someone with a cognitive impairment. Not only is there risk of physical injuries, but falls often lead to a loss of independence, which can increase caregiver burden. It may cause the patient to have to be institutionalized, which greatly impacts, for most people, the what matters part of the 4Ms. And because one fall doubles the risk of having another, our prevention really, really has to be proactive and not reactive. We can't start thinking about prevention after a fall occurs. We have to think about it and this patient population early. There's also an emotional toll. Frequently, a fall causes a patient to be afraid of falling, which causes them to move less, which increases the risk of more falls, which increases the risk of more social isolation. So it really is a snowball effect. So we need to be proactive in preventing falls in these patients. So these are some concrete tools and strategies you can use in any setting, outpatient or inpatient or long-term care facility. And like I said, no single intervention is enough. It's not like you can just do one of these and check it off. Yep, we've done fall prevention. You really have to be constantly re-looking at all these different strategies to make sure there's not something else we can do better to help prevent falls. We need a bundle of strategies that are consistently applied and individualized to that person's individual cognitive state and physical status. So with the environment, of course, we've talked about this, removing rugs, improving lighting, orientation, using those different things to help cue them if that's appropriate for where they're at in their disease state. Reviewing medications regularly, trying to deprescribe when possible to get them on the lowest effective dose, making sure they're not on any medications that are on the Beers criteria, which are medications that are potentially inappropriate for use with older adults. Increasing supervision, setting up routines and safe activity spaces, encouraging regular exercise that includes things like balance training. Tai Chi is one of the evidence-based strategies for decreasing fall risk. And then communication. This is a joint effort. Caring for older adults of any group requires a collaborative effort, typically with a family, friends, or caregivers. Okay, so again, just to, this forums framework, it's not just a theory, it's hopefully for everyone going to be a practical, person-centered roadmap for keeping older adults safer and happier. Using this approach, we focus on what matters the most while preventing what matters the least, the avoidable injuries that we do not want to have happen. So, in every case with dementia or delirium or both, the forums is a way to help us organize our care, how we're addressing fall risk reduction, and our prevention efforts. So with mentation, we want to identify changes in condition early. It's very important that older adults have someone that they talk to regularly so that if there is a change in their cognition, they can contact a medical provider and get a workup going so we can address those issues early before they get septic or before they get very, very sick. With medication, we want to deprescribe as much as we can to the lowest effective dose of only medications that really improve health, quality of life with minimal adverse effects. Mobility, we want to make sure they're moving regularly, using assistive devices correctly. And with all of this, we want to align all of our plans with the patient according to what their preferences are, what matters to them, what do they want to be able to do in their life with dignity and happiness. Okay, so what can we all do in our normal life to try to keep our brains healthy? We want to stay mentally active. We want to encourage our patients and family members to keep learning, doing puzzles, social engagement, reading books, things like that. We want to move our bodies every single day, having good nutrition, eating more of like a Mediterranean diet, healthy fruits and vegetables, things like that. We want to try to manage chronic diseases that can increase our risk for dementia. So we want to manage blood pressure, diabetes, cholesterol, things like that. Avoid smoking and excess alcohol. And sleep and stress management often get overlooked, but can have a really big impact on brain function. So, trying to make sure that we are helping our loved ones, family members with stress management and sleep if they're having sleep issues. So, how can you prevent falls? With patients with dementia and delirium, knowing the signs of dementia and delirium and trying to get a diagnosis sooner than later is very helpful because then it allows for better planning for the future. We want to encourage safe, regular movement, not immobility, because as we know, immobility begets more falls. So we want to try to help keep our friends and family moving. If you notice that a medication seems to increase confusion or imbalance in yourself or a family member or a patient, speak up. Let your healthcare provider know so that they can make some changes. Keeping those environments clutter-free, providing reassurance, reorientation as appropriate, and routines is also important. And then asking the actual patient what matters, what's your favorite part of your life? So we can make sure that we are trying to help them maintain doing those activities that mean the most to them. So lifelong habits matter. We talk about a lot of these topics in regard to older adults, but these habits and things that we should be doing happen way earlier in life. So no matter who you're interacting with, it's important to encourage that activity. Exercising, Keeping our brains moving and learning all the time is helpful. And then multi-generational strategies as far as education, safety, and healthy living. I grew up in a home where both my grandmothers lived with me. So some of these habits that we were encouraging with my grandmothers kind of um, trickled right down to me, which is nice. All right. And then when to seek help. Anytime there's signs of memory issues or a change in condition, it's important to not ignore them. It's important to talk to a healthcare providers. If the change comes on suddenly, especially after an illness or a surgery, it could be more likely be delirium, and an urgent evaluation is likely needed. So you don't really have to have all the answers. You just have to speak up and ask for help for either yourself or a family member or a patient. Local resources and support. There are local memory clinics. You don't have to navigate this journey alone. Many communities have these memory clinics, caregiver support groups. I know there's the Alzheimer's Association helpline that runs different support groups for families, patients, and caregivers. So some key takeaways: dementia is a chronic progressive condition, while delirium is typically acute and reversible, but both of them significantly increase the risk of falls in older adults. That's why early recognition and prevention matter so much. Whether you're a healthcare provider, a caregiver, a community member, you have a really important role in promoting brain health and keeping people safe. So by incorporating the four M's, mentation, medication, mobility, and what matters, we can deliver care that's not only clinically effective, but also person-centered and meaningful to the patient. Um, and that's it. Thank you for your time and for being a part of helping our older adults stay safe and living lives that are meaningful to them.
Thank you so much. This was a wonderful presentation. So happy to have you here today. For those on the call here, at this point, we'd like to open the floor for the audience to be able to ask questions to our speaker. You're welcome to come off mute if you're interested, or you're welcome to type it in the chat, and I'm happy to direct them over to our speaker. I believe there is a Q&A as well, so let me take a peek. So it looks like we do have a question in the chat. What is your overall impression of the Pointer trial findings and how they can translate into Georgia practice landscape? If you're
Oh,
familiar. They did
uh,
share a link too.
yes, I was just glancing at that. Can you, April, can you tell me where your like context is coming from? Are you a provider?
I started to hear you.
Yeah, same.
That's funny. I'm driving, so the context behind that is with the domains that the U.S. Pointer Study has put out there, and that relates to what they're calling their recipe: exercise, cognitive and social engagement, nutrition, and health monitoring. But one of those pieces is reaching out to like our partners within Georgia and thinking about what those guidelines and that recipe might look like here in Georgia in a local kind of population context. So for exercise and Tai Chi, love that one. How would something like that be lifted in a local level to provide that recipe?
Yeah, I think that's a really good question. And that's really where I think in the current landscape of what's going on, partnering with our community partners is really important because in different areas in Georgia, I know, there's some faith groups that provide a lot of resources to older adults and families having to navigate the complexity of caring for older adults. So I think the fact that it's a multi that they're talking about in that study is correct and on the right track. I think it's a little tricky because there's so many different communities within our country and even within our state that have a different kind of network and different resources available on a local. So I think it's not going to be a one size fits all, but I think it would be great if different communities could kind of tweak the recipe to really reflect the resources available. Because I do think families need very concrete call these people. You can try that, give them instead of these esoteric like the four M's,
Mm.
I think it's helpful for families to get really concrete context and resources that's helpful. And so maybe the trick is that people that work with older adults, maybe we need to get together and write specific recipes for specific communities that align with what's important to the specific community because different communities have different values and priorities also. So it's an interesting thing. Thank you for bringing that study up.
That was great. Thank you so much for that. And thank you, April, for asking that. We do have one other question I see. What foods would you suggest that promote brain health?
Yeah. So I think in general, this is what I tell my patients is to just try to stay away from processed foods. Fresh fruits and vegetables, lean meat if they eat meat. Getting enough protein. Protein is important, especially for older adults with fall prevention. A normal physiologic change that happens with aging is sarcopenia, where we start to lose muscle mass. So there is a need for increased protein to some degree. So things like that, making sure they're getting some protein in their diet, and then not trying to stay away from processed foods would be kind of a very general basic recommendation, I would say.
Perfect. Thank you. Looks like we had another one pop up. Kay Graham shared, I was so glad to hear you talk about the importance of family members advocating when they see sudden change. This is hard for many to do, especially if the provider is not immediately responsive. Can you give some suggestions for how they might approach a provider when they notice a sudden change while hospitalized?
Yes. I totally know what you're talking about because I've had patients' families before. It's almost like they feel guilty coming to me with a concern or something. So I at least try to totally validate that that is not only appropriate, but it is the right thing to do. These patients need advocates. So I think I tell them don't ever feel bad about advocating for your loved one or your family member. So if you have a healthcare provider that you bring a concern up and you feel like they're not responding appropriately, I would ask to talk to them again, ask them to explain why they want to do whatever their plan of care is, and then pushing back if you don't get an answer that's satisfactory to you. You should be able to hear the explanation from the provider and understand their rationale. Um, and if that doesn't happen, I would suggest keep asking.
That's very helpful. I know that's one of the biggest suggestions and tips to give patients is be an advocate or have a caregiver, a strong caregiver that will be your advocate. Looks like we have a hand raised. You are welcome to unmute and ask your question.
Hi, Jennifer. Thank you so much for your presentation. I liked it. And currently, I'm doing internship in a dementia respite care program, and we have some clients. And one of our clients, she struggles with a sleeping issue, and because she went to different doctors, her family doctor provides some sleeping pills for her, but she feels it didn't work that well, so she went to another doctor and get some other pills, and then because they always give her some dose, but she adjusted the dose by herself, so she feels like, oh, I don't need so much, so I just to take half of the dose or something like that. So she missed it a little bit. Then we can tell like she sometimes feels dizzy and sudden change. So, but it's hard for us to tell if it's delirium or dementia, cause or because dementia, they can have some bad days, right? So could be something like her normal days, but we can tell the sudden change. So we don't know what we can help her. So we should like, I'm thinking maybe we should bring her to just one doctor to take a review of all her pills, see if there any conflict between them,
Yeah.
or right. Is there any other
Absolutely. So,
suggestions?
yeah, so one thing I teach my students is you should encourage older adults when they go to their primary care provider, who theoretically should be kind of helping them navigate all their different specialists.
Mhm,
Bring all the medications they take in literally a brown bag, bring the actual bottles with them so that then the provider can look and see all the different things that they're on and also can check the patient's understanding of, do you know what this particular medication is for? How
mhm,
often do you take it? Because with especially with folks with dementia, they frequently will get to a place where they can't manage self-administration of their
mhm,
medication on their own. So we have to be kind of screening for when that's happening so we can catch it before something bad happens, like they take 2 times or 3 times their blood pressure medication in one day, and then they fall because of that, right?
yeah.
So I think bringing all the medications to one provider, uh,
Mhm,
it you know, medical providers frequently kind of reflexively prescribe, and that's not really what we want for older adults. We want our patients to be on less medications that is a simple regimen, hopefully, so that we can try to avoid polypharmacy, avoid interactions, all those things. So, but you're right. I think just bringing the medications to that provider and just telling them she's, seeing multiple providers. We just want to make
mhm.
sure she's on the medication she really needs to be on.
Okay. Thank you very much.
Yeah.
Yeah, thank you. Are you familiar with, I believe pharmacists will review
Yep.
medication for
Yep.
patients as well. So if
Absolutely.
people are maybe more comfortable with that or it's convenient for them, might be another option.
Absolutely.
Oh,
Pharmacists are
pharmacists, they
great.
do that?
Yes, they sure will.
Oh, nice, nice. I'll let her know. Thank you.
You're welcome.
Yes, thank you for that wonderful question. We do have two more in the chat. One is back related to foods and healthy eating. Have you heard anything specifically about blueberries being good for brain health?
Blueberries are definitely good for your brain. They're full of antioxidants. So absolutely. And they're sweet. So a lot of times patients with advanced dementia, their tastes sometimes change and they at least, and this is anecdotally actually speaking, but my patients tend to prefer sweet things. So sometimes blueberries can give them that sweet taste that they like too. So blueberries are great.
Wonderful, thank you. And I see one more here. This may be very specific, but would you please tell us about the protective or preventative role of ingredients or substances like creatine or caffeine?
Sure. So with both of those, you should definitely talk to your healthcare provider to be sure that that's appropriate for you with your medical conditions that you may have. So always talk with your specific medical provider about any supplements or things like that. In general, things like creatine can be helpful with muscle growth, but you have to be exercising. So it's also somewhat dose dependent, but there are potential side effects to caffeine also. Caffeine certainly in some patient populations, it may be appropriate to help with wakefulness, but also you have to be careful because can have cardiac um, adverse effects as well. So again, with both of those, there may be a place for some of those, but I would talk to your individual provider to discuss that situation.
Perfect. Thank you. I believe that is all we had in the Q&A. Since we have a few minutes, I'll ask one for you that came up while you were speaking. You mentioned the Beers criteria. I'm not as familiar with that. Could you just share like a little bit about what that is?
Yeah, so the Beers criteria is a list of medications that are potentially inappropriate for use with older
Mhm.
adults. Now, there's exceptions to that all the time, but we teach our students about it just to keep in mind, like, for example, anticholinergics or things like that that can increase fall risk. may not be always appropriate. So, yeah.
Perfect. Thank you. That's really helpful. I'm going
Yeah.
to do some research now just because I was unfamiliar. So learn
Sure.
taking something away today. And then lastly, of the lifestyle habits that you had mentioned, like physical activity, social engagement, diet, sleep, things like that, would you have a suggestion of which one you would say is the strongest for protecting brain health, or maybe your top contender for folks to focus on?
Well, I guess it depends where they're at in their life. Of course, I think the younger we can get people moving their bodies
Mm.
regularly, eating healthy diet can prevent so many chronic diseases like hypertension, diabetes, things like that. I think that's very, very important. The other things are important too, though, so I don't want to take away from those.
Yes,
But those two are so foundational to long-term health, um, that I would start with that probably.
that's perfect. That's very helpful. Thank you. I believe that's all the questions I have. I'll give it one last call for any questions from our group here this morning. Seeing and hearing none, we're nearing the end of our time today. So I would like to thank our speaker for sharing her experience and expertise today. I would also like to thank all of you for attending today and joining us this morning and asking some really wonderful questions. Love when you all are engaged and happy that we were able to answer some of those questions for you. As a reminder, this session was recorded and will be available on the Injury Prevention Research Center at Emory's YouTube channel in the coming weeks. If you have additional questions for our speaker, please don't hesitate to reach out to any of us. We're happy to answer any questions that might pop up. And lastly, please complete, there will be a brief survey at the very end of this session that will pop up. We do ask that you please complete this for us. We do appreciate any feedback that you can provide to us so we can keep these sessions going. We hope to see you all next Friday for the next Falls Free session with Alyssa Perkins with the Atlanta Regional Commission on support and self-care for the caregiver to support Fall Prevention Awareness Month throughout September. Again, I'd like to thank our speakers and all of our participants who were able to join us today. Thank you so much for spending your Friday morning with us and hope you have a great weekend. Bye, everyone.
Thank you very much.
Thank you.
Hi, thank you.